other aspects of traumatic brain injury. And this literature is just centered on few centers in the country, like All India Institute of Medical Sciences, NIMHANS, PGI Chandigarh, and many other institutes which are coming up, and so many other places that there is no literature. We further carried out to review the status of guidelines, status, how these are being followed. We did a systematic review of these databases, which included all the literature which was published from India by Indian authors. And these were the studies which has more than 50 cases. Each study should have more than 50 cases. Then we further analyzed, and the outcome of interest were based on the randomized trial on consort guidelines, observer studies on STROP guidelines, patient age, gender, mechanism of injuries. On this, there were only 72 papers, which included 1962 patients. And the distribution of data reporting variables in publications is shown in this table, how we have presented our experience and data to the Indian literature. There is a limitation. We have not included all the data and unpublished literature. So there is a huge limitation of the study, but what is there in the literature is being analyzed here. 10 studies discuss about the body regions involved. 17 discuss about clinical presentation. 14 demographics. Like that, follow-up guidelines. Only 2 studies tells what all guidelines are being followed for traumatic brain injury in India. Then management outcome, prediction model. Long-term follow-up was grossly lacking in all these studies. What is happening to the patient? There is no study which discuss about the economic impact or pre-hospital care. Usually young male, and the trends remain static almost. It doesn't change with time. They are continuously being involved in traumatic brain injury. Then the major causes are RTA, almost more than half cases, 55%. In-hospital mortality, 24.6%. It can be difficult to predict because the cases with minor head injury, those who have not come to the hospital, those who are being not involved, we don't know. So all these data are not very reliable because these are all hospital-based study what we have seen, and this mortality has not changed significantly over a period of time. Regarding quality of data also remains almost static over a period of time. Randomized controlled trials has a 55% score on consort guidelines, 66% on STROP guidelines. These are the results from individual studies, not on the based on our data, because this data is not uniformly available. The data quality is not very good to analyze the data in detail. So this study says that most of the patients have moderate disability, almost half of the patients. Pre-hospital care. There are a number of studies which tell how to treat patients, what all there is. We don't have any understanding how it is happening in the country. But if we see this study, only 22% of the patients were shifted to the ambulance, through the ambulance to the hospital. And we don't know what type of quality of these ambulances, with what kind of facilities they were shifted. Only 12% patients could reach to the hospital within 1 hour. And significant number of patients came directly to the hospital, 13.5%. Government hospital, most of the patients went to trauma with government hospitals. Again, it is difficult whether they got any primary care or not, and care is available is largely unknown. A major limitation presently, we don't know about the rehabilitation. At least 1.5 million people need rehabilitation services every year, which are concentrated to only few centers, those who have specialization in rehabilitation. That also, a number of aspects of rehabilitations are there. like psychological, social, details are not available. What is happening to these patients once they sustain traumatic brain injury? There are some papers have come from All India Institute of Medical Science and other places, and the studies are going on. But we need to really document data to have our own concepts and guidelines. To summarize, despite significant increase in incidence of TBI in India, the quality of published literature on traumatic brain injury is low. Data regarding management protocol largely unavailable. Outcome of TBI is often restricted at discharge, that is whether the patient was discharged alive or dead. Neuropsychological outcomes are not addressed. We need to work on methodological excellence and on preventive studies. Recently, the guidelines have been adapted from the Western guidelines to adapt to our need in our country from Neurotrauma Society of India. This full document is available at the Neurotrauma Society of India website, which can be downloaded and printed in. And still, this document, the limitation is not supported based on our data. So when I was asked to present about the guidelines in our country, basically there is nothing scientific basis to tell what we are doing at present.
Thank you, Dr. Agrawal. It's nice deliberation. Topic is open for discussion. Any questions? Yeah.
No, only from MCI website we have taken, sir.
What happened that after the patient was discharged, about the cognition, speech, memory and all those, any study in India about that?
That's why, sir, we were discussing that such kind of studies are largely unavailable. Very few variables they have used. It is difficult to rely on the quality. Such kind of studies were not there, what we searched in the literature, sir.
Dr. Amit, actually, there is nothing you cannot say, but we are still developing. Like, there are few things which have come up. Exclusively trauma center. Now government has started All India Institute, and many of these All India Institutes are exclusively started trauma centers, and there is definitely guideline. And pre-hospital care in almost every state or cities, most of the cities are now ambulance provider. And third thing is that we have already started to overcome this follow-up problem, trauma registry, which has been started, I think, 2-3 years back by Dr. Diwan. So we are not that anything, nothing is there, but still we are developing, and it will go further. That's it. Thank you.
I agree with Dr. Tripathi. What we want to say, we don't have guidelines. We have practices, what we are doing, but we don't have guidelines. What we practice is different. So if guideline means somebody else also should be able to replicate. That thing we need to organize ourselves and put in a better way. So these practices can become guideline. All our senior professors are here. What they practice, if they can document, the next generation can take advantage of that.
Thank you very much for this comprehensive overview of the search to develop guidelines in India, and emphasising the importance that's been shown in many studies of having guidelines and protocols to direct management, and particularly emphasising, as you have, the pre-hospital phase where guidelines are often lacking. And I just wanted to point out that on the AASNS website we have placed a set of guidelines specifically for the pre-hospital phase, and specifically for the medico, the doctors and the hospitals of first contact with injured patients. These guidelines are based on an Australian set of guidelines, which are practice guidelines. They are available on the AASNS website. Anybody who wants to take them and use them, modify them according to their own requirements. Thank you.
I agree with Professor Riley. Actually, what we have, we need to further do a publicity or make people aware that what we are making available for them. The next step should be we should keep collecting our experience and we should spreading the message that these things are available. I think it will be a good idea to share with everybody what details are available for current practice.
Professor Das. Professor Das.
Small in number. I worked in NIMHANS for some time, and that is probably one of the institutions who have pioneered in post-trauma deficit assessments, and that too in the minor head injuries, about how they have fared in subsequent years. And their data is nearly 30% develop post-trauma syndrome needing cognitive retraining amongst the mild head injuries.
Same thing I was
and
telling.
other, just a moment, about guidelines, it's unfortunate we as a tribe, as a group, do not want to follow any guidelines. That is our unfortunate fact. Why we do not follow? In one department, wherever it is, 3-4 persons, they will have 5 different guidelines. Unless we make up our mind to follow a procedure for some period of time and then study what has happened, it will not take up. Thank you.
Major General Prakash Singh.
Good morning. I think biggest problem is our healthcare system in the country. As a country, we don't have a uniform healthcare system. It's a state subject. Unlike small countries where it's a national health services. So it is imperative that at state level there's a policy and there is a registry for head trauma in every state, and which is compulsory. So you collect correct data and then follow it up. And it's digitized. So that if you have got a patient clinical history, everything on documented, so that you can retrieve it. So that data creation is the first step, and it has to be administrative action. Otherwise, we'll be having hospital-based studies, and which are not population-based studies, and there is no regular follow-up of these patients. Once a patient leaves the hospital, he may come to you, he may not come to you. So that is the first step. So I think we should have a state for a compulsory health registry, brain trauma registry, and from there you can retrieve your data and your guidelines can evolve. Thank you.
My comment is, as a neurologist, what I have seen, we manage the case of head injury. Subsequently, some of them, they come to me also. I see that like stroke, head injury cases also, they do improve, unless they are in a vegetative state or something like that. So there is a particular spectrum of cases who keep improving. And though the problem is so much in our country because of the population, but I just wanted to know whether there is any attempt on the part of the government of India or government of states or any institutions like Allied Institute, Army and other things to have some sort of protocol like hospice practice. This institute people or the doctors or a designated particular person goes to the house of the person, not everybody. It's just like something like hospice practice, which is practiced in US and other thing like that. I just want to know that.
Let me answer that. The Neurotrauma Society of India, for the last 5 years, during their annual conference, they are planning to have a Indian guidelines. But as has been said, for making any guidelines, data is essential. I appreciate Professor B.S. Das. If there are 3 neurosurgeons in a unit, all 3 will have different protocol. One will not agree with the other protocol. He will say, my protocol is better than the other protocol. So data is not. But whatever data also is available, like the National Crime Record Bureau, they also record, because you go to police, if there is trauma, it's a road traffic accident, this is registered and informed the police. In turn, each district and in each state, they have the National Crime Bureau record where they mention regarding the road traffic accident, the traumatic brain injury and spine injury. But unfortunately, all the cases are not recorded. All the cases, some of the minor cases, they do not report to the hospital. The Odisha government guidelines are that if a patient reaches with any trauma, even at the primary health center, they should not pass on the patient directly if it is quite far up to any district hospital or to the capital hospital or to the medical college. At least whatever required, the ABC must be done at the level of primary health center, suppose serious injury. And ambulance are also available for shifting them to the nearest neurotrauma center if it is a severe traumatic brain injury. But unfortunately, the medical officers sitting there, they do not, because they do not know where the driver, where the petrol, the ambulance are there. But from where they will give for that purpose, they send to the nearest subdivisional hospital where again there is no neurological facility. Once they see in the casualty itself, they are not trained in trauma and they are shifted to the capital hospital again where there is no neurosurgeon. So what happened in the process, the golden hour is lost and actual record is not there. And when they reach a tertiary care hospital, medical college hospital also, the beds are very limited and they cannot handle, suppose 10 SC medical college has got 20 trauma beds, you will find any time walk in, there will be 60 patients lying on the floor and other places. They cannot also handle them, treatment is otherwise. So these are the problems. But government has clear guidelines like for preventing head injury. Suppose you are driving a bike, the driver as well as the pillion driver both have to use helmet, otherwise, but nobody observes. As I have said, they have said the petrol pump will not give petrol unless you put on helmet. But they'll take the helmet, keep there, they'll put, because some camera is there, so, and they'll come out without putting. So it is the public awareness, their response, unless that is done, you cannot make guide. That is very important. The public awareness should be there. They should be involved. Then only you can make guidelines. Of course, there are guidelines as per the Western literature guidelines, what to be done in the pre-hospital phase, what has to be done in hospital in the emergency, what has to be done on the almost similar part. It cannot be little different, it's almost same. But only thing is, we have to practice them. It is not being practiced because we have very different in opinion while handling the cases. We don't have consensus or anything, even amongst our 2 or 3 people. That's the reason why this cannot happen. This cannot be accepted. This is being put up every year in the Neurotrauma Society. It has still not been accepted, all the guidelines. What has to be done pre-hospital, in hospital, in the emergency, and what the guidelines for management, all these things, and rehabilitation, how it can be done. They have been put up, but is not being accepted by many. Therefore, a final guideline has not yet come.
Okay, if you don't have any further questions, so we'll move on. Thank you, Amit.
Okay, we'll move on to the second lecture. The speaker, Dr. Namkayu Yu, Recent Guidelines, Advances and Evidence is Management of Spinal Cord Injury Patient with Prolonged Spinal Shock and Asia Grade 1. Dr. Namkayu.
Thank you for your kind introduction, Chairman. Good morning. I'm Nam Gyu from Aju University in South Korea. Today I talk about the recent guideline advances and the evidence in management of spinal cord injury patient with prolonged spinal shock and Asia Grade A. In 21st century, first guideline for acute spinal cord injury was introduced at 2002 in neurosurgery. It contains from pre-hospital care to nutritional support, and it was revised in last 2013. Between 2 guidelines, there was another guideline. In 2008, early acute management in adults with spinal cord injury was published in Spinal Cord Medicine. Many associations, including AASNS, CNS, was participated in consortium. And its 2008 Spinal Cord Medicine guidelines suggest triage protocol and pre-hospital immobilization. And steroid and other drugs were not recommended for neuroprotection. And surgical procedure, anesthetic concerns were guided, and pain and anxiety control was recommended. Secondary prevention and prognosis was noted. But currently, most widely used guideline is the 2013 from neurosurgery US guideline. Now, this is most widely used. So, in these guidelines, each guideline was classified by its power of evidence. Class 1 has high-quality randomized control trials. Class 2 has less quality randomized control trials, or prospective comparative systematic review of Class 2 studies. Class 3 has no randomized trials, only just case series. And first, pre-hospital cervical spine immobilization after trauma. In pre-hospital phase of spinal cord injury patient, cervical spine immobilization should be done in cervical spine or cord injury or potentially injured patients. Triage should be done trained and experienced emergency medical service personnel. And immobilization of trauma patients who are awake, alert, and not intoxicated, without neck pain or tenderness, who do not have an abnormal motor sensory examination, and who do not have any significant oscillation injury that might detract from their general evaluation is not recommended. Level 3, another guideline, the rigid collar and supported blocks on backboard with strap is effective in limiting motion of cervical spine, and it is also recommended. However, sandbags and tapes is insufficient to limit the motion, so it is not recommended. And especially, cervical immobilization is contraindication in penetrating trauma because it delayed the resuscitation and caused increased mortality. Transportation is also important, and level 3 evidence is the nearest capable definitive care medical facility is the most first choice, and if possible, the specialized acute spinal cord injury treatment center is recommended to transport. And this is my case in our hospital. The patient visited emergency room with alert mentality, but just after check the lateral cervical spine X-ray, the patient complains dyspnea, and then immediately fall into respiratory arrest. Emergency room physician did intubation. It was successful, but then lateral X-ray again. This display is so bright, but there is C2-3 dislocation occurred after intubation. So this is some bad case that not according to the guideline caused the additional injury of cervical spine. And clinical assessment, most of neurosurgeon or other physicians to treat spinal cord injury use this American Spinal Injury Association Internet Standard for Neurological and Functional Classification chart. And outcome measurement, the Spinal Cord Independence Measures version 3, and the International Spinal Cord Injury Basic Pain Data Set is also recommended. And then, now I talk about the radiographic assessment. Awake, asymptomatic patient. Level 1 evidence is the awake and asymptomatic, and normal neurological examination is not need the radiographic evaluation. Also, discontinuable cervical immobilization is recommended. And awake symptomatic patient, high quality computed tomography CT scan is the recommended imaging study. If CT scan is available, there is no need to additional 3-view cervical spine radiograph. However, the CT scan is not available. 3-view cervical spine series is recommended. Also, this should be supplemented with CT scan if we cannot identify lower cervical area by the routine X-ray. And awake symptom patient, another evidence level 3 is the high quality CT is normal, or 3-view or cervical spine series showed normal spine anatomy. So cervical immobilization continue, the patient will be asymptomatic. And discontinuation of cervical immobilization is confirmed by the dynamic flexion extension radiograph. And normal MRI scan within 40 hours of injury, also that is evidence of cervical immobilization discontinuation. And last, the treating physician decide to immobilization removal or not. And And the last group of the patient is obtunded or unevaluable patient. Relevant evidence is the high-quality CT scan is recommended as an initial imaging modality of choice. If it is impossible, three-way view cervical spine series is recommended. Also, CT scan is more valuable in this case, in this patient. And this is also my cases. This X-ray, lateral view of X-ray is taken by emergency room because the patient has superos mentality and unable to evaluation. But we can only see the upper level of C4 vertebral body. And then we take CT scan. We can see C5 bursting fracture and slightly subluxation of vertebral column. And MRI scan also show definite cord injury. And we finally treat anterior vertebral body fusion. And Radiographic Assessment also, there is level 2 evidence. Sorry. High suspicion of spinal cord injury with normal CT scan, specialists should be involvement in further management for the patient. And also the in the patient who obtunded or unevaluable patient with normal high quality CT or three-way view cervical spine series, the following recommendations should be reconsidered. Until asymptomatic, cervical immobilization should be continued with a normal MRI scan within 40 hours of injury. Also, immobilization will be discontinued. And same to symptomatic patient, the physician can decide to removal of cervical immobilization. But the routine use of dynamic imaging in unevaluable patient is not recommended. And then we try to close reduction in fracture dislocation injuries. Early close reduction is recommended, especially in awake patient. But there is additional lateral injury. Reduction is contraindicated. Magnetic resonance MR imaging is not routinely used pre-reduction because if the patient is awake, we can continue to examine during the close reduction. But the patient is unevaluable or there has loss of mentality, we have better to do pre-reduction MRI. But pre-reduction MRI did not indicate prognosis or result of outcome. And most of spinal cord injury patients have spinal shock and neurogenic shocks cause hypotension and hyperfusion of the spinal cord. So most patients admitted in intensive care unit or a similar monitoring setting is recommended. And all devices monitoring, cardiac, hemodynamic, and respiratory monitoring to detect cardiovascular dysfunction as respiratory insufficiency is recommended. And hypotension should be corrected, especially systolic pressure should over the 90 millimeter mercury, and maintain mean arterial pressure between 85 and 90 millimeter mercury for first 7 days is recommended. This is a hot debating issue still. There is NASCAS 1, 2, and 2 trials, so many neurosurgeons used methylprednisolone before the 21 centuries. But after many other studies that revealed the methylprednisolone causes many side effects, mortality, and does not improve motor score. So in this guideline, methylprednisolone is not methylprednisolone for the treatment of spinal cord injury is not recommended. And high-dose steroids are associated with more harmful side effects, including death. Also, GM1 ganglioside is for treatment of acute spinal cord is not recommended. Also, recent study, the 2015 Journal of Neurotrauma, methylprednisolone for the treatment of patients with acute spinal cord injury. There is a significant higher rate of total complication in NASCAS 2 methylprednisolone group. But below this here, in this page, lower side, there is two there is two articles that protest that the positive effect of methylprednisolone, because in the side of philosophical debate and the patient paper, but this is not evidence of the scientific result. And the acute trauma central cord syndrome, the level 3 evidence is almost same in spinal cord injury. Medical management, including cardiac and respiratory monitoring, maintain mean arterial blood pressure. Also, early detection in fracture dislocation injured patient. Surgical decompression of the compressed spinal cord, particularly if the compression is focal or anterior, is recommended. And spinal cord injury without radiological abnormality, SCIORA, there is a MR imaging study is recommended, and entire spinal column evaluation also recommended. Additionally, the spinal stability should be assessed in SCIORA, but the angiography and myelography is not recommended in SCIORA patient. So the level 3 evidence is the immobilization period that recommended for up to 12 weeks. Early discontinuation of external mobilization recommended for the patient who became asymptomatic and whom spinal stability is confirmed by flexion and extension radiograph. And avoidance of the high-risk activity for up to 6 months following SCIORA is recommended. And also spinal cord injury may be combined with vertebral artery injury following by the non-penetrating cervical trauma. Level 1 evidence is the screening tools that is widely used, modified Denver screening criteria for suspected vertebral artery injury. I checked the suspicious findings, expanding cervical hematoma and neuroexamination incorporated with the CT scan, and cervical spine fracture patterns, subluxation, fracture extending to the transverse foramen, and fracture of C1 to C3 vertebral body. And diffusion axonal injury with Glasgow-Coma scale below 6 is highly suspicious of the vertebral artery injury. And the most important imaging modality is conventional catheter angiography. Magnetic MR scan is also recommended in diagnostic of vertebral artery injury. The treatment is not well established because the anticoagulation, antiplatelet therapy, or no treatment is individualized based on the patient vertebral artery injury. The role of endovascular therapy in vertebral artery injury has not yet been defined. There is no recommendations. This is my case. The patient visit after traffic accident ER with slightly swelling of the neck. First, we check the CT scan. There is the C6 level. The left side transverse foramen and transverse process is broken, and that broken bone fragment impingement in transverse foramen. And MR scan showed the prevertebral hematoma and also expanding to the anteriorly. And finally, angiography showed the total occlusion of vertebral artery. And spinal cord injury patients have many complications. Deep vein thrombosis in thromboembolism is contained in this guideline. Level of evidence is the low molecular weight heparin, rotating bed, combination of modalities recommended, and low dose heparin in combination with pneumatic compression stocking is also recommended. But low dose heparin therapy alone is not recommended. Early administration of venous thromboembolism prophylaxis within 72 hours is recommended. But the vena cava filter is not recommended as a routine prophylactic. And another level 3 evidence is the Doppler ultrasound, plethysmography, venous occlusion plethysmography, venography, and clinical examination is recommended as a diagnostic tool of the the deep vein thrombosis. And the uterine support is important. Indirect calorimetry is the best mean of determining the calorie needs. And the early enteral nutrition initiated within 72 hours is safe and recommended. This is conclusion. This guideline suggests immobilization of cervical spine, clinical assessment. Radiographic evaluation is highly quality, CT scan is more valuable, and early closure reduction. But the pre-reduction MRI is valuable in unevaluable patient. And cardiopulmonary monitoring should be continued and to maintain mean arterial pressure. And do not use methylprednisolone. And central cord syndrome is same to the spinal cord injury patient. Secure patient should be examined about spinal stability. Vertebral injury is the most important thing is suspicion, and CT angiography should will be helpful. Deep vein thrombosis, every time we consider the early administration of venous thromboembolic prophylaxis. Vena cava filter is not recommended. Nutrition is the early enteral nutrition is safe. Thank you.
Okay, thank you, Dr. Namkui. Very nice presentation. We will, Dr. Ganapati, who will be on presenting on role of telemedicine management of head trauma, is already on web. That will be a web presentation. So I will request Namkui to be take your seat so that at the end of the coming presentation we will have a questionnaire. Can you get me? Thank you for your presentation.
Thank you.
We will come to question hours after the coming next presentation, right? Can you make it?
Can you hear me?
Yeah.
Okay. Is my slide on the screen?
Is they clearly visible? Or?
Okay. At the outset, my apologies for not being physically present there. My respects to, I can see Professor Sanathan Red, Dr. Sarla Das and Dr. B.S. Das, Brigadier Sahu and others. Thank you very much for giving me this opportunity. In the next 1,200 seconds, I hope to convince every one of you that today in 2017, it would be malpractice if, next slide please, it's not moving. Next slide. It would be malpractice if we do not deploy telemedicine in the management of neurotrauma. All of you are familiar with the tremendous urban-rural health divide, particularly in the availability of neurosurgeons and neurologists. A paper which I had published in February 2015 showed that 935 million Indians live in areas where there is not a single neurosurgeon available. Obviously, trauma, head injuries particularly, is a national epidemic today, and it is necessary that in many cases neurosurgical expertise is required. It is interesting that neurosurgeons have been associated with the deployment of telemedicine. In 2000, we are now demonstrating since February 2002 live demonstration just of 2 cases, just to show you what is it that we can exactly do. Before I go into that, this was just a demonstration to show that the Indian Space Research Organization decided to get into telemedicine after the successful demonstration of the first VSAT-enabled teleconsultation by me in February 2002. In the last 16 years, tremendous progress has been made, not only in telemedicine, but also in the deployment of telemedicine in neurosciences. Several papers have been published, both from India as well as the rest of the world. Today, telemedicine is being used routinely by the US Army, many other armed forces, and I'm very happy that the Indian Armed Forces also have started using telemedicine. Now, just to give you a brief idea, in Madras, from my department, out of the consultation, we have done about 19% of all consultations, teleconsultations from the Department of Telemedicine in Chennai alone are neurological, neurosurgical consultations, and at least 1/3 of this relate to trauma. 90% of course are review cases, follow-up patients, but we still do see patients with head trauma for the first time at least one a week or so. It is extremely simple. This is a slide which I had taken in 2002, 15 years ago. As all of us know, it takes just 3 minutes maximum for you to do a reasonably detailed neurological examination. On the top left-hand side, you can see a small hemorrhagic contusion which any resident in neurosurgery would be able to give appropriate weightage. But for a non-neurosurgeon, they get terribly anxious about it, particularly the parents. These patients are unnecessarily transferred to the nearest neurosurgical center, which could often be several hundred miles away. A detailed post-traumatic peripheral nerve examination can be done. Even sensory examination can be done with the patient himself being asked to touch every dermatome. I have made several diagnoses. I have localized peripheral nerve lesions purely based on the patient's subjective sensation of whether the sensation is diminished or not. In other words, today distance is meaningless. Geography has become history. Now here is a typical example of an ordinary phone. This is not even a smartphone. Now all of us see hundreds of patients like this. These patients don't live a few kilometers away from a neurosurgical center. Most often they are hundreds of kilometers away. Now this is a patient discharged after a primary brainstem injury. With an ordinary telephone, I asked the patient to take different photographs, and this is all the information that I require. And this was done in the house of the patient. You can see what an amount of effort and time and money they would have had to spend to bring this person to either to me or to any other neurosurgical department. It's just a question of mindset. I think it's time that we start deploying mobile phones, particularly in the management of head trauma. This is one of my favorite slides. A few members in the audience may have seen it. This was again, I think in 2003 or 2004, I don't remember. I had given a talk in Port Blair, Andaman and Nicobar Islands, at the invitation of the government at that time. 3 weeks later, a smart technician calls me in my house and says, "Sir, there is an unconscious patient here. There is no doctor here, no radiologist. What do I do? I am a CT scan technician." I said, "Okay, just go ahead." And we managed to get hold of a nurse. And with an ordinary torch, I was able to, and these phones, I'm talking of 2003, 2004. Today, every phone, a video can be taken. I was able to make out whether the pupils were dilated, whether it's reacting to light or not. Very simple diagnosis of temporal lobe contusion. The ventricles are slightly squashed. Obviously, there is some amount of cerebral edema. Patient is unconscious. And believe me, from my house, I was able to manage this patient, just advising an MBBS doctor who came later on how much mannitol to give, when to give, etc. 10 days later, the patient was discharged. Now, this can be done routinely. This can be done hundreds of times a day. Today, CT scans are available in every district, even in every big town. But you don't necessarily have either a neurosurgeon or even a radiologist to interpret it. Here is a patient. The patient happens to be in Nigeria. Again, a case of head injury, compound depressed fracture, operated. And here you can see a bead of pus. Just 3 ml of pus which is coming out. It takes a couple of minutes for an experienced neurosurgeon to talk about osteomyelitis, underlying brain abscess, etc., and inform the local general surgeon how to treat this patient. This patient happened to be in Nigeria. This was an interesting case, a 74-year-old male in a small town in India. And I checked, now this is a bilateral chronic subacute subdural hematoma, head injury. Now, a couple of years ago, I would definitely have operated on this patient. But today, I just didn't have the heart when the person was apparently alert and oriented. So I was so confident, I told him to Sir, camera, sir. Please look at the camera. That's better. This is the patient's house. In the patient, a patient with a bilateral. Okay, please get up. Now, I brought the easy era. My teachers taught me to treat a patient. Please focus the camera. Can you zoom out the camera and shadow? And I'm only able to see in the house. I want to see him. That's better. Very good. Okay, right. Will be based on very good. Over the period of 6 weeks, the subdural resolved completely without any intervention on my part at all. This is just to show the power of what telemedicine can do, and a patient need not come at all. Now, this of course was a borrowed slide.
We're looking for all the usual things in a stroke patient, any evidence of acute intracranial hemorrhage, any early ischemic changes,
and today it is so simple.
Hyperdense artery sign,
head injury patient is having a CT scan done. Everyone
surprises, other explanations for
even as the
a stroke syndrome, things that might mimic stroke.
Give a reading without the patient, without
the beauty of this is that
see the patient at all. Yet another example, you can see here. Okay, I can see a little. Okay, both sides. Okay, fine. I can see that very nicely. Okay. So this is again from my house. Yeah. Polytrauma. The duty doctor is present to the patient to be. Okay. First, it's all the time for a senior specialist at 3 o'clock in the morning to go and the emergency ward and see a patient. Okay. At least 40-50 patients I have. Hello. Like this from the company. Ordinary connection at home. Okay, kanna mudunga and kanna mudunga irki mudunga. That a senior neurosurgeon is kanna irki mudunga. Okay, kanna taranga within a few minutes. Now here again is another patient, vegetative state, primary brain stem injury. This patient is a new patient that been sick, but he how couple of years ago all able to swallow. Patients anymore. I don't. I insist. Patients and urine motion kaisa. After all, why should
sir motion हल्का सा tight रहता है मतलब
can go within 1 week. All this is done. He passes motion. Now here is another example. You can see here a brief head injury a couple of days ago. This was a very smart parent who apparently had listened to me at some time or something. About a minute after the seizure started, the father just took out the mobile phone and took captured a video like this. So this simple video gives us enormous information. As most of us know, when we physically examine a patient after the seizure, it's very unlikely there will be a neurological death. Now, telemedicine can be used in so many ways. I'm sure every one of us have had this experience. We are not gods. We cannot save every patient. Now, this person normally would have been put into an ambulance and shifted to a tertiary care hospital 80, 100, 200 kilometers away. And I'm sure we all know what happens when somebody dies in the road. The check post, getting the certificates, it's a nightmare. So I took the responsibility and I told the local doctor, you record in the case sheet that patient evaluated through telemedicine, Dr. Ganapati, etc., put the time, this patient is an extremist, unlikely to survive, and there is no point in attempting to shift the patient. And exactly as predicted, in about 30 minutes, he developed an irreversible cardiac arrest. The family was actually very thankful to me that I had saved them not tens of thousands of rupees, but the trauma of trying to bring back a dead person from a tertiary hospital. Ladies and gentlemen, we are in a stage of transition, and I think, and I got interested in this as early as December 25th, 1995. India's first multiple organ transplant following certification of brain death was facilitated by me, and in the first 10 years I was involved in promoting the concept of brain death and recognition. Today we have reached the stage where we are in an advanced stage of trying, and I'm sure it's going to happen in my lifetime. In the next 2 years, we are very sure that we will be developing drones. Drones in India, this is already in the experimental stage. We are having a major conference in a few weeks from now, and I foresee that very soon drones will be used to make available drugs. For example, a simple thing like mannitol may not be available in the remote areas and mountainous areas somewhere. A drone can go and take these drugs. Similarly, we are going to have mobile CT scans. We are going to have portable CT scans. The whole world is going to change, and you cannot practice modern neurotrauma in the next 2-3 years unless telemedicine is an integral part of your healthcare delivery system. I could go on and on like this, but if there is time, I would like to take a few questions. Ladies and gentlemen, this is the India of today. On the top two, you see those two little babies preparing for their IIT entrance exam or probably the NEET exam. And the bottom slides you can see octogenarians and nonagenarians absolutely at home with a laptop and a desktop. How many of you know that in Kerala, one of the districts was the first district in the whole world to be recognized with 100% computer literacy? Gone are the days when we talk about an illiterate India. Today we are talking of a computer literate India. We no longer piggyback. We no longer leapfrog. How much can a frog leap? We pole vault. And I think it will be a shame if we do not. We have the czars of modern technology. We have the IT experts of the world. We have the most fantastic medical centers, the Mecca of medical care in India. And I think the time has come where we need to integrate information communication technology. When I started my neurosurgical career, ICT was intracranial tension. Today, ICT is information and communication technology. So this is just a few clinical examples to show that today it is possible, the technology is available, it is cost effective. All that is required is a change in the mindset of the people. And I implore you, I thank Brigadier Sahu once again for this opportunity, and I really think we need to prevent patients from unnecessarily traveling. Thank you once again for this opportunity.
Thank you, Dr. K. Ganapati sir. If there are any questions, you can ask from here so that he can answer from web. Dr. Tripathi. So there are questions for you.
Yes, please.
Good morning, Professor.
Morning.
I'm Ellen Tripathi from Calcutta. It's really enlightening to see you. We also practice telemedicine in Medica group of hospitals. We have now 15 hospitals in Eastern India. And you being the pioneer, it was really exciting to listen to your vision for the future for all of India. And just one small query from you, sir, clarification is, what is the medical legal standing as far as telemedicine is concerned? I know you mentioned about the patient dying with the RTA, that you could say that he's not going to survive. But what is the medical legal responsibility we as doctors have at this stage of our medical practice? Things are happening in West Bengal. I'm sure you're aware of the situation elsewhere also. So please enlighten us, sir. Thank you so much.
This is a question which I'm asked in every single talk which I have given in the last 17 years on telemedicine, without a single exception. And right from 2000 to 2017, my answer is the same. The answer is very, very simple. I do not know. Now, having said that, please be reassured that the courts of India now have a backlog of 20 to 30 years. It will take another 30 years, not in my lifetime definitely, will the courts decide where the case is to be filed in a telemedicine encounter. Is it going to be in Madras where the teleconsultant is, or is it going to be in Jalandhar where the patient is? Even an FIR in the city of Chennai, Tinagar police inspector refuses to take an FIR when the crime has been committed in Guindy or somewhere else. So please, please, please as a past president of the Telemedicine Society of India, I publicly state that the Telemedicine Society of India will come to your rescue if there is any such medico-legal issue. One, having said this, some of us are working on this. A draft bill has been submitted, but unfortunately, this is not the priority of the government. I think in a couple of years, in maybe 2-3 years, the position will become clearer. Number 3, having said all this, telemedicine is not important at all for medico-legal purpose, sir. What is important is the doctor-patient relationship. If you have made an inexcusable technical, an error of judgment which all of us can make is excusable. But if I record or if I write in the case sheet that this patient need not be transferred when it could be a potential extradural hematoma and it turns out to be an extradural hematoma, obviously I will be taken to task. So at the end of the day, it is clinical judgment, clinical wisdom that is important, not the technology component of it. So please don't get worried about the telemedicine. Having said this, we had a users meeting of ISRO about 2 years ago. Roughly about 900,000 teleconsultations have taken place so far, 80% of which of course is teleophthalmology. To the best of my knowledge, there has not been a single case anywhere in India where, forget the court, where even this has come to the notice of the administration or regulations. I think it will be several years more before we even think of a person challenging the decision taken by a teleconsultant and go and seeking legal redress. It's just not going to happen. Having said all this, what we do is we have an informed consent whenever we give a teleconsult, where we very clearly say that there are limitations of teleconsultation. The most important, I expect the consultant to have the maturity of clinical judgment not to give an opinion when there is a slightest doubt. In the earlier years, at least in 5% of cases, I have said, sorry, I cannot give an opinion, the audio is not good, the video is not good, bandwidth is not good, too much of breaks, etc. You have to come personally, etc. So at the end of the day, it's all about clinical judgment and wisdom.
Professor Ganpati, so nice of you this thing lecture, and so nicely you have teleported yourself and the entire speech of yours to us, and also you have involved us in your that teleportation cloud. Thank you very much. I like that particular thing.
Yes.
You brought the concept of drones. I know the drones are flying all over the continents. It will be a very nice thing if the drones can be used to be decentralized to the patient places and get the information, and that also can be roped into medical practice in due course of time, isn't it? Drones.
Yeah, please go ahead. What is your specific question, or are you giving an observation? I totally agree with you.
Observation, and also what is your vision, future vision for the employment of the drones to get the information? Yes. Much better than what we are getting today. And recently, just we are thinking how we can decentralize the rehabilitation processes in post-traumatic and post-stroke cases to their houses. I think this will be a very nice thing if that can be employed more frequently. What is your vision about it?
DRDO, Ministry of Defense, as well as the National Institute of Advanced Studies, which is a component of the Indian Institute of Science, Bangalore, the National Research Forum in Bangalore. These three organizations are in a very advanced stage of fabricating, making drones, etc. And a few doctors are also involved with this. I am certain that in another 2 years or 1.5 years, the government will give permission for some clinical studies if you want. What we are particularly looking at is transporting organs. See, as neurosurgeons, we also have a responsibility to facilitate the diagnosis of brain death and to play a proactive role in getting organs for multiple organ transplants. So one of the drones will be a major help in shift. Today, an organ can be brought from Delhi to Chennai by a commercial flight. But from the Chennai airport to come to the hospital, even with a green corridor, even with police and all that, takes a lot of time. So it is anticipated that drones will definitely play a role in transporting organs in brain dead patients. And as you know, 80% of brain deaths is certified falling trauma. So I think those who are involved in management of head injuries also should have some interest in recognizing brain death, certifying brain death, and in facilitating multiple organ transfer. Drones definitely are going to be a part of clinical practice, maybe 2 years, 3 years, 4 years from now, at least in the big centers, in the big cities.
Thank you so much. Thank you. Sir, one more question for you.
Professor Ganput, it's Dr. Peter Anastasiadis from Adelaide, South Australia. We've been involved with tele-rehabilitation, and I just want to ask you another question about the liability, the safety in terms of medico-legal aspects of telemedicine, and I'm just interested in what you do in relation to implementation of your opinions and your recommendations. You know, who are you giving them to? Do you have a proctor or someone at the far end from you to actually follow through and to implement your recommendations? And where is the sort of long-term continuum of care? Is it just with that telemedicine, or do you have follow-up?
That's a good question. Now, again, the practice of telemedicine necessarily has to be customized to suit the individual requirements. Unlike Western countries, it's impossible, nor is it, in my opinion, necessary to have a doctor at the other end. Why are we advocating telemedicine? Because there's a tremendous shortage of healthcare providers. So we do have doctors at the other end when they want a secondary or a tertiary level opinion. I have overseen about 150,000 teleconsultations from Madras. 99% of our teleconsults are without a doctor at the other end. We have a trained person most of the time, either a nurse or somebody who is trained in the nuances of telemedicine. So far as the government is concerned, they are aware of this, and there is no rule, explicit rule, which says you must have a doctor at the other end. And as I said again, and I repeat it, it has to be tailor-made, individualized. The teleconsultant must be mature enough not to proceed if he thinks there is a remote possibility of some liability issue coming. The third important point is, unlike Western countries, we are not yet a litigious society. In the US, when a doctor sees a patient, the first thing he does is this guy going to file a suit against me or not? Let me accordingly decide on what I do. Whereas here, it's not like that. And two, there's a very interesting, several papers which very clearly show that even in Western countries, the question of litigation arises not because of the poor results of the treatment. It almost always arises because of the very poor communication between the consultant and the patient. I have had several instances where I honestly thought that I had made a mistake, I had made an error in judgment, but the patient sympathized with me, and the patient actually felt sorry for me purely because of the excellent communication. So once again, sir, what I would like to emphasize is, so long as there is an excellent communication, tender loving care. I belong to the BC era, before computers and before Christ are one and the same. I was the last neurosurgeon in India who was trained before the CT scan came. So long as you're able to empathize with the patient, so long as you're able to communicate with the patient, liability just will not come. Liability arises only when you have an unhappy, dissatisfied patient. Unhappy, dissatisfied, not because of the technical results were good, not good, but purely because you did not tell him what could happen and you gave him too much of good things to believe in. That's my personal view.
Thank you, sir. Before we conclude the session, we have questionnaire for Dr. Namkui.
one more question.
Okay. Sir, Ganapati sir, one more question for Professor Mohanty to you.
Dr. Ganapati, have you laid down any guidelines?
Can you please focus the camera on the speaker? I can only see Brigadier Sahu.
Hey, just turn the camera towards Professor Mohanty.
I think it's a long time we have met, but anyway, you have seen me earlier also so many times.
I still can't see you. Where are you? I don't know. Okay.
So my question is that do you have laid down any guidelines which has been approved by Neurological Society of India or any government body regarding the care of the patients on telemedicine, neurosurgical patients?
I'm delighted to hear this question. Until very recently, telemedicine was a dirty word. And I know what I went through in the last 15 years, even to talk about telemedicine. The next issue of Neurology India, hopefully there'll be a review article, a very detailed review article on telemedicine and neurosciences, which will cover almost all aspects of medical neurology and surgical neurology. If one of you could please take the initiative, and if there is a requirement or if I get a communication from NSI, I'll be very happy to spend effort and time and try to develop a guideline. It's an excellent idea. I honestly didn't think about it, and I'd be very happy if you can take the leadership, and I'll be very happy to work with you and get this going. It will take some time, but I think it's worth it.
Thank you. Now, is there any questions for Dr. Namkui regarding his talk, recent guidelines, advances, evidence in management of spinal cord injury patients? Thank you, sir. Just we have one speaker who has not been questioned during. You can hold on, or thank you very much, sir.
Okay, thank you. I'm signing off now.
Thank you, sir. Yeah, is there any? Is there any questions for Namki?
What about the bladder management in these cases? How to manage the bladder in spinal cord injuries?
How do we manage bladder? Urinary retention.
Okay. First, the patient visit the ER. First, we insert the enduring catheter because the urinary bladder dysfunction causes many serious complications. And most AISA patient has no bladder function, neurogenic bladder, because they continue to keep the enduring catheter in their bladder. But I think I'm not fully understand your question, but the bladder function is recovered by the patient recovering of AI scale, the more than scale C or DE. They not need more bladder dysfunction treatment.
Is there any more questions?
A patients in spinal cord, SCI grade A, how do you manage them? And what is the chance of recovery of such patients?
You mean recovery rate?
Yes. ACR grade A patients.
A patient. That is very, yes, that is very sad. I remember that in about 10 or 20% improved the ACR grade from ACR A, but they cannot reach the D or E, only improve B or C. I think the recovery rate is very low in ACR in spinal cord injury patient.
Okay, thank you, Nampu, Dr. Nampu. If there is no other question, we will conclude the session here. Thank you again to all speakers and all delegates. Nice interactions. And again, thank you to all. We will conclude this session here also.
Thank you so much, all the speakers. Thanks to the chairpersons. I would request all the chairpersons to be there on dais, please. And I would request all the speakers, Dr. Amit Agarwal, Dr. Namkyo Yu, and Dr. K. Dr. K. Ganpati cannot come. I'm sorry. Two on the dais, please. Dr. Amit Agarwal, Dr. Namkyo Yo, on the dais, please. We'll have a small felicitation. I would request Professor Dr. Pradipta Tripathi to felicitate Dr. Amit Agarwal. Thank you, sir. Can we have an applause, please? I would request Professor Dr. B.K. Vaishya to felicitate Dr. Namkyo Yu. Thank you, sir. Now, I would request Dr. Amit Agarwal to felicitate Dr. Pradipta Tripathi. I would request Dr. Namkyo Yu to felicitate Professor Dr. V.K. Vaishya and Dr. A.K. Mahapatra. Thank you so much, sir. Thank you, the chairperson, and thank you to the speakers. Now we'll be having a small tea break and we'll be resuming back here by 10:30. Thank you.